really want to thank you for your attention. And I think now we'll go ahead and turn to some questions from the audience. So while we're waiting for a couple of questions to pop up, I think what we may potentially do is highlight, for instance, some of the emerging vaccine therapies for kidney cancer. There are two in particular that are being assessed right now in prospective clinical trials. One is AGS-003. This is a very interesting autologous dendritic cell vaccine for renal cell carcinoma. This is an agent that's derived from the patient's own immune cells, stimulated in the presence of lysate from the primary tumor and re-injected back into the patient. In a small phase 2 study that we performed in association with colleagues across the U.S., what we observed was a substantial clinical benefit associated with the combination of sunitinib and AGS-003 in patients with intermediate and poor risk disease. From the standpoint of toxicity, I think this vaccine brings up very interesting questions because in and of itself, it didn't seem as though it contributed much to the toxicity profile of sunitinib therapy. But of course, there are toxicity questions that arise from the nature of the procedure required to generate the vaccine. Cytoreductive nephrectomy is required in the context of this clinical trial. So moving forward, we'll have to potentially weigh the strategies for vaccine development into the potential toxicities of these drugs. So I'm seeing a couple of comments, but while we're waiting for a couple of questions, I think I might just go ahead and expand on the other vaccine therapy that's available for metastatic renal cell carcinoma in clinical trials, and that's an agent called IMA901. This differs greatly from AGS-003. This is a multi-peptide vaccine. And this particular vaccine strategy is quote-unquote off the shelf. So this is a prepared vaccine that you can deliver to patients. The vaccine's been assessed in a randomized phase 3 trial comparing sunitinib alone or sunitinib in combination with the vaccine therapy. In that particular trial, we're still awaiting results, but again, pretty minimal toxicity in association with the drug. So as trials move forward, comparing nivolumab and ipilimumab to current standards of care, if these vaccine therapies become approved, given their benign nature, it's really going to introduce a very, very interesting discussion of whether or not the low toxicity profile of the vaccines might encourage us to use those over some of the other emerging immunotherapeutic strategies. So I see a couple of questions popping up here. The first question is that vaccine available in the Philippines? So right now, AGS-003 is being evaluated in the randomized phase 3 ADAPT trial. This is led by Chris Wood from MD Anderson and Bob Figlin from Cedars-Sinai. That trial is still accruing, so foreseeably patients from the Philippines can receive the agent on clinical trial here in the U.S., but commercially the agent's not available at the moment. IMA901 was being assessed in a randomized phase 3 study that was recently completed. Again, this was sunitinib with the vaccine versus sunitinib alone, and that trial's closed, so I'm not aware of any other avenues to receive IMA901 at this point. A question has been asked regarding what the most helpful resources are for patients in dealing with these toxicities. I've always suggested that patients have very lengthy discussions with their physicians before starting any particular agent. And also it's worthwhile taking a look at the package inserts for these drugs and patient handouts that have been developed by clinicians for patients in this regard. These are relatively comprehensive. I do find that this can potentially dissuade patients from the therapy, given the scope of toxicity that's often outlined, but it leaves no room for surprises. These manuals and handouts are often very comprehensive and all-encompassing. One's asked the question of how you adjust the dose of Sutent upon the development of transaminitis, and does transaminitis effect ever go away with tolerance? That's a great question, and I think that we have to acknowledge the fact that with sunitinib and pazopanib and with the VEGF-directed therapies in general, there is a black box warning associated with those two drugs in particular, and we have to be very cognizant of the risk of hepatotoxicity. In terms of dose adjustment, I find that typically if somebody has grade 1 or 2 AST and ALT elevations it's reasonable to potentially consider continuing on the drug without significant dose modifications. For grade 3-4 toxicity, I find that dose interruption until resolution of toxicity is the preferred approach. And it's important to refer very closely to the package insert here, because you'll see very strict criteria and guidelines that highlight how one should manage dose adjustment in the context of elevations of both the total bilirubin as well as the AST and ALT. That's very important to keep in mind in clinical practice, because if you see the two elevated in concert to a certain threshold, it certainly can bear risk of fatal hepatotoxicity. So excellent questions so far. Perhaps what we can do is highlight some of the other potential toxicities that we might encounter with mTOR-directed therapy and how we might ameliorate them, and VEGF-directed therapy as well. One thing that we didn't dwell on is how one might manage hypertension. I think that some of the interesting data that's emerged in recent months has suggested the potential role for angiotensin converting enzyme inhibitors in the context of hypertension for the VEGF-directed therapies. Using ACE inhibitors and ARBs for VEGF-directed therapy might be the preferred approach, and in some retrospective series has been associated with greater clinical benefit. That's always been a lingering question in my mind, and we finally have some, at least preliminary evidence to suggest that there might be a preferred drug class to manage the hypertension observed with VEGF-directed agents. While we're waiting for some other questions, perhaps we can explore some of the other toxicities associated with VEGF and mTOR-directed therapies in some greater detail. For instance, we can potentially discuss the pneumonitis that's incurred with mTOR-directed therapies and how that can be more definitively managed. Some of the tables that I've highlighted in this talk are quite helpful. The pneumonitis in association with the mTOR inhibitors is being increasingly recognized in the context of some non-renal cell studies. I've seen a reported incidence up to 16 to 20%. So that's 1 in 5 patients in whom we have to be mindful of the risk of pneumonitis. Always very prudent to get the pulmonologist involved very early on in the management of pneumonitis for mTOR-directed therapies. I think that it's important to potentially recognize in the context of these therapies that you shouldn't jump in immediately with steroids until you've eliminated any sort of infectious risk. Bronchoscopy performed by the pulmonologist, BAL, and culture, those are all critical facets prior to potentially embarking on corticosteroid therapy. Now, having said that, once you've adequately ruled out the risk of infection, I think that corticosteroids can be immensely helpful in treating drug-related pneumonitis.